Hey guys, my name is Andrew Morgan and I'm a senior exercise science student at West Chester University of Pennsylvania. And today we're going to be discussing a topic known as PAD, or Peripheral Artery Disease. I'm going to go into some of the basic causes, risk factors, and really how people afflicted with this disorder are affected in an exercise setting, because as an exercise scientist, it is my job, I feel, to prescribe exercise in a safe way to all populations, not just a normal, apparently healthy individual. So let's get to it. So the National Heart, Lung, and Blood Institute describes PAD as a disorder where plaque builds up in the vasculature carrying blood to the head, organs, or limbs. Primarily, the literature states that PAD afflicts the lower extremities, so you'll see blocks going down to the legs. And people will also experience colored indications, which we'll talk about later, but basically muscle cramping due to the lack of blood flow, which is going to be very important later on. But just keep in mind that it's a block in an artery going to a limb. So as I did research into PAD, I kept coming across three extremely similar looking words, either atherosclerosis, arteriosclerosis, or arteriolosclerosis. And I had a little bit of a hard time finding a distinction between the three things, but I found a video on Khan Academy which described it rather nicely. Atherosclerosis is more along the lines of a process. So the inside of your vessels is extremely smooth, like a plastic tube. And then over time, or through other causes like lifestyle habits, diabetes, or smoking, the smooth surface of the inside of the vessel becomes adhesed or damaged or just roughened in some way. And then this roughened surface makes it easier for things like plaque to build up on the inside of your vessel, eventually creating a block. So atherosclerosis is that the process of the abrasing and then the adhesing of the plaque to the inside of the vessel. Arterial and arteriolosclerosis, or just sclerosis in different parts of the body. So arterial would be a sclerosis in an artery, and arteriolosclerosis would be sclerosis in a small vessel, an arteriole. And then the impact of the sclerosis, which is really important in an exercise setting, is that it decreases a vessel's compliance. So its ability to stretch and to dilate and constrict when blood is forced through the vessel. One can experience a variety of complications from PAD. Right off the bat, you're at an increased risk for cardiovascular disease and coronary heart disease, which really makes sense because if you have a block somewhere out in the system, the vasculature system, the heart's always pumping against that block. 100% of the time, 365 days a year, 7 days a week, it has to pump against that block, and that's added stress all the time. So that will increase your likelihood of having a cardiovascular event, which when we look at how we're going to apply exercise to these individuals, the focus is on aerobic exercise and decreasing that possibility for having a cardiovascular event. Other complications include a decreased ability to palpate pulse in that extremity, which really makes sense also because say you have a block in the vasculature going to your right leg, your pulse isn't going to be nearly as prevalent in that right leg as, say, the left leg, which doesn't have a pulse. In extreme cases, the individual may have gangrene or a dying of the tissue in that blocked limb. You can even lose some hair. You can become impotent. Numbness, weakness, and heaviness in the muscles is highlighted because, yet again, that's going to really impact how our individual performs with exercise because they're not going to be able to supply oxygen to that working tissue as well as a non-blocked limb. The patient may experience pain in the extremity or a burning or aching, again from the lack of blood flow. They will have restricted mobility in that limb, and they may have thickened or opaque toenails. So those at risk of developing PAD are really those over the age of 50, because remember, as we were discussing before, the inside of our vessels is inherently smooth, and plaque's not going to stick to them, a smooth surface. However, as we age, the insides of our vessels become abrased, and our ability to vasodilate and vasoconstrict is drastically affected. So the integrity of the vessel becomes diminished. This opens us up for plaque buildup in these specific vessels. So if you take a look to the left side of the screen, I have a graph presented by the CDC. I pulled it off their website, but it just shows the prevalence of PAD in men and women based on age. So you can see when you're 40 to 49, you have a relatively low chance of developing peripheral artery disease. However, by the time you're 80, those rates jump up to 20 and 25% respectively. So that leads us to believe that age is a very much leading cause of PAD. So other than age, risk factors include a history of heart disease. If you're a postmenopausal woman, you have a greater risk for developing peripheral artery disease just due to hormonal changes. If you have a family history of high cholesterol, blood pressure, or pulmonary vascular disease, you're going to be at greater risk for peripheral artery disease. If you have coronary artery disease, high blood sugar, blood pressure, or cholesterol, not just a family history, if you actually have them, you're going to be at a greater risk. If you're obese or if you're physically inactive, you're going to be at a greater risk for developing peripheral artery disease. One really interesting thing that I found was the demographic statistic of prevalence of PAD. So if you take a look to the right, I found this chart off the American Heart Association's website, but at age 70 through 79 and those greater than age 80, if you're an African American, your instances of peripheral artery disease are double that of those of Caucasian or Hispanic Asian descent. American Indians have similarly elevated levels of prevalence of PAD, just not nearly as high as those as the African Americans. This could be due to a whole number of things, socioeconomic status, societal lifestyle choices, diet, who knows. But I just found that to be truly astounding that it's that much more prevalent among African Americans. Also, those who have diabetes and those who smoke are going to be at a much, much greater risk for developing peripheral artery disease, just because diabetes by nature damages or can damage the lining of vasculature when left uncontrolled, and smoking is just, I mean, that's just bad for you all around, so that doesn't surprise me in the slightest. All right, so how is peripheral artery disease diagnosed? There's a number of different methods that they use to diagnose PAD, and it all depends on the severity of your PAD. But an angiogram is typical, so they'll take an x-ray of arteries for blockages. They'll also use a thing called Doppler ultrasound flow studies, which I thought was pretty cool, but they make like a 3D image of your internal vasculature, which is pretty cool. You also have magnetic resonance angiography, which is similar to Doppler ultrasound, but it's just creating an internal image. Different mechanisms, but similar ends. But two very common low-cost methods for diagnosing PAD are the ABI index, or the ABI, and the treadmill exercise test. And I actually thought that the ABI was pretty clever, and I didn't really think of it initially, but you take blood pressure in your arm, and then you take blood pressure in your leg. So if you have peripheral artery disease, we said it typically affects lower extremities, the blood pressures would be different from that of, say, your brachial blood pressure to, say, your femoral blood pressure. It's going to be different just because there's that block there. So if you have a ratio greater than 9, that's considered fine, normal. But below 0.9 is considered pathological. So you have PAD, peripheral artery disease. The other method is similar to the ABI. It's the treadmill exercise test. So you take two blood pressures, same way, blood pressure on your brachial region, blood pressure on your femoral region. And when you start exercising, we know that systolic blood pressure increases. If the systolic blood pressure does not increase in that leg, there is a block there, and you can be diagnosed with PAD. Obviously, these are done by a medical professional, medical doctor, stuff like that. So treatment of PAD, well, the answer is with everything that we learned in exercises. It really depends. So treatment's based on a variety of factors. It's based on your age, your medical history, your overall health before you were diagnosed, the extent of the PAD, as well as your tolerance to specific medications. Doctors will prescribe medications designed to increase dilation and blood flow. You may need some sort of bypass surgery. Surgeries are sometimes implemented. I saw a statistic done by a University of California teacher. He said that 20 to 30% of individuals with severe PAD may need surgical implementation. They may need to have surgery. However, Johns Hopkins on their site said the number one thing to treat PAD is to never get it. So we need to make lifestyle changes. We need to avoid alcohol consumption. We need to avoid tobacco usage. We need to keep our blood pressure down. We need to increase fruits and vegetables in our diets. We need to control diabetes. The list goes on and on and on. We need to make smart lifestyle decisions so we don't have this developing in our future. That's the correct answer. I just wanted to take a second to go over vascular compliance before I go into the exercise portion of my presentation. Because this is really important because we're dealing with blocked arteries, and that will, in nature, decrease blood flow drastically. But how drastically? So if you take a look at Pausoli's equation, a decrease in vessel radius will increase resistance to the fourth power. So a 50% block will increase resistance by a factor of 16. So if you have a blocked artery, this means that less blood flow is traveling to those muscles. And by nature, that will decrease performance. So keep this in mind. Exercise is going to be harder for these individuals. The goal of exercise training in those with peripheral artery disease really depends on the individual, because someone with peripheral artery disease can have really mild or non-existent symptoms. They may only experience a little bit of cramping in that leg due to decreased blood flow, or the individual could be completely debilitated and not be able to walk up the stairs. So you really have to, it's a hit or miss. You got to find and scale your exercise to the individual. But our main goal is to reduce limb symptoms. So we're trying to increase blood flow, therefore decrease claude indications. So the individual is going to be experiencing less aching, they're going to be experiencing less burning, things of that nature. We're also trying to lessen the physical disability. Like I said, these people may have no disability, or they may not be able to walk up the stairs. There's two different ends of the spectrum. And we're trying to decrease the possibility of a cardiovascular event. This is really important because remember, these individuals are at an increased risk for developing coronary heart disease. So we really have to keep them aerobically trained to strengthen their heart. My apologies for how small this table is, but I kind of lost a little bit of it in the screenshot. But it's right out of a case study done by the National Institute of Health, and basically they took a group of 150 individuals with mild to moderate PAD and asked them to walk at a moderate intensity pace, so 40 to 60% of the max heart rate. And the goal was to do it in 6-minute bouts and accumulate a total of 50 minutes. Now, the individual was allowed to cease a 6-minute bout if they rated their claude indication pain of 3 to 4 out of 5. So if they experienced a large amount of pain, we allowed them to stop until the pain subsided, then continue with the exercise. Over the course of the training regimen, which was 2 months, claude indications were decreased by 180%. So the exercise, the aerobic exercise, drastically increased how these people were feeling on a day-to-day basis. The ACSM recommends a very similar exercise prescription to that of the National Institute of Health, and it looks very similar to any other ACSM aerobic prescription. It's 3 to 5 days a week, 30 to 60 minutes each bout. The one thing that you want to be careful with these individuals, though, is that we cannot have them do anything max exercise because they're going to have that extra stress on the heart. So if you're going to max exercise test them, they need to have the supervision of a medical professional, such as a medical doctor. That is out of our scale of our knowledge, and we need someone to pass off on that. Primary modalities are the treadmill, our track, or outdoor walking. They can also use an arm ergometer or a cycloergometer, but they didn't really elaborate on the benefits of that opposed to a treadmill. The treadmill is the preferred modality. Just to wrap it up, the ACSM recommends that we focus on aerobic training. However, they do see the benefits in resistance exercise, so we divide lower body and upper body. We use a lot of dynamic lower body exercises and we always want to focus on aerobic strength because we want to strengthen the heart. Thanks for listening, guys. Here are my sources.